Everyone, in this question, we have a 80-year-old woman with metastatic breast cancer developing severe refractory burning neuropathic pain in her hands and feet a few weeks after starting paclitaxel. Her current pain regimen, hydrocodone acetaminophen, is ineffective as she is still experiencing 8 out of 10 pain. What is the most appropriate next step in pain management? This is something we see a lot, especially with our oncology patients, neuropathic pain from chemo. It is a real challenge for patients and can be tough to manage. And the question that we have today is hitting on this directly. So we have a 80-year-old on paclitaxel that develops this classic burning pain in her hands and feet. And this is chemotherapy-induced peripheral neuropathy. And the taxane drugs are going to be famous for it. She's on paclitaxel and she's already on a opioid. So she's on hydrocodone acetaminophen, but it is not cutting it as she's still experiencing 8 out of 10 pain. So what is our next move for this kind of pain? Now, you might think of drugs like gabapentin for neuropathic pain. This is famous, and it is certainly used for other types of neuropathic pain, but the kicker here is that for chemo-induced peripheral neuropathy specifically, big studies have actually shown that gabapentin by itself often does not provide much benefit. So while it is in our arsenal, it is not the go-to here. The answer is going to be, in this question, duloxetine. Why duloxetine? Well, the American Society of Clinical Oncology, or ASCO, which gives us some of the more solid evidence-based guidelines for cancer care, they actually recommend duloxetine as the first-line agent for treating chemotherapy-induced peripheral neuropathy. This comes from a big randomized study that showed it helped reduce pain scores more than placebo. Now, the full disclosure here is that the benefit they saw was modest, so there's always a bit of a talk and some controversy even about the absolute best first-line drug. You might see other guidelines like NCCN, the National Comprehensive Cancer Network. They often list opioids as first-line for cancer-related pain in general, and then put drugs like antidepressants like duloxetine, as well as anticonvulsants like gabapentin as first-line adjuvants for neuropathic pain specifically. So where do opioids fit for chemotherapy-induced peripheral neuropathy? Even though they might be the second line for chronic non-malignant neuropathic pain by some guidelines, if a patient has active cancer and has severe neuropathic pain, opioids are absolutely a reasonable additional choice. Many pain experts actually use a dual approach. They start with an opioid in the acute setting to get the pain under control and then layer on a non-opioid neuropathic agent like duloxetine. The hope is that once the neuropathic agent kicks in, you can eventually taper down or even off the opioid. So the big takeaway here is that when you're dealing with chemotherapy-induced neuropathic pain, duloxetine is generally considered your first-line management option. If you need a mnemonic to remember this information, you can use my silly mnemonic, duloxetine dose chemo pain.